This is a podcast for nursing to 42 for postpartum or families after birth. So, we're going to talk a little bit about normal postpartum care. What is couplet care? So we'll be talking about this a little bit in OB orientation, but basically couplet care is when a nurse is taking care of both mom and baby and treating them as one unit instead of two separate patients. So there are certainly some advantages and disadvantages to that. Some of the advantages is it helps to streamline care. There's less disruptions to mom, allows for better bonding, better rest and sleeping. When you have one nurse who's kind of an expert on both patients, there's better overlap and consistency of care versus if you have two different nurses taking care of the two different patients, where they would have to constantly be updating each other. Where they'd have to be constantly updating each other about what's going on with each patient. Some of the disadvantages, some of that can fall on the nurses. Some nurses may have more of a comfort with taking care of mom and maybe not with baby, maybe kind of outside of the realm of their scope of practice of what they prefer to do. It can also sometimes be a little more exhausting to the mother if we're on a unit that does couplet care and there isn't that option to send the baby to the nursery for mom to get some rest while she's there. We're going to go over normal procedures in OB seminar in terms of, how often we take vital signs and things like that. So normal changes in the postpartum period. So we always want to be culturally sensitive when we're taking care of our patients and be aware of that certain cultures and ethnicities respond to the postpartum time frame differently and have different expectations. There are some cultures where the mothers themselves are very hands-off in terms of care of the newborn, where their main responsibility and goal is to rest and take care of themselves, where sometimes when we go in and we see that, we think, oh, maybe they're not bonding with their baby or there's something wrong, but that just may be part of their culture and the expectation of how the mother is to care for herself. We always want to think about the age of the mother. How we approach and care for a 14 or a 15-year-old first-time mom is going to be very different from a 40-year-old first-time mom. So I always want to think about the age of the mom and where she's coming from in terms of how we educate her and help her through this process. Typically, for a low-risk, healthy woman, vital signs after delivery will be every 15 minutes for the first hour, then every 30 minutes, usually for about an hour. Then after that, it's going to really depend on the unit and how they organize things. Some units will then do hourly for an hour or two. Some will do Q4, Q6, Q8, or Q shift. But those first 2 hours, it's pretty standard. Q 15 minutes for the first hour, and then every 30 minutes for the second hour, and that's for the low-risk patient. Blood pressure should stabilize within the first 6 hours after delivery. You need to use your critical thinking and think blood pressure may be a little low, especially if she had a higher amount of blood loss at delivery. It could be high due to oxytocin use or because of pain or anxiety, or if she has preeclampsia, hypertension, any other issues going on. Pulse might be a little low post-delivery. Once again, think about the fact that she's just had blood loss. If her pulse is over 100, once again, use your critical thinking. It could be because of fever, dehydration, pain, anxiety, could be infection, but usually you don't see that immediately postpartum unless she was having some type of infectious process during her labor and birth. Respiratory rate should be normal, could be depressed if she's had an epidural or narcotics, and certainly it would be a concern if her respirations were less than 12. Temperature is going to be anywhere between 98 and 100 typically. Over 100.4 is usually a sign of dehydration, especially if it's within the first 24 hours. After the first 24 hours, it's usually going to be a sign of infection. So normal changes, involution. Involution is basically the work that the uterus has to do to get back to that pre-pregnancy pregnant state. Prior to pregnancy, the uterus is about the size and shape of a pear, and then it obviously gets very, very large depending on how many babies she has in her uterus and how much fluid she has and how much the baby weighs. And the uterus suddenly has to go from being very full and distended with baby fluid, placenta, all of that, to doing the work of contracting back down to the size and shape that it was prior. So when should involution be completed? Well, obviously by the 6-week postpartum mark, the uterus should be back to what we say normal, but the uterus will never be back to its pre-pregnant size. It's always going to be slightly larger after a woman has a baby, but that process should be completed by 6 weeks postpartum. One of the important things to remember as nurses, by the 2-week mark, so by the time a woman is 2 weeks postpartum, we should no longer be able to palpate her fundus or her uterus abdominally. It should be below the pubic symphysis. So if a woman comes in for a visit, she's having any kind of complications, and it's after the 2-week mark, and you're able to palpate that uterus abdominally, that's usually a sign that something is wrong. So some factors that can slow the process down. Some of the big, more common ones are infection. Infection's a big one. An infected uterus is not going to contract back down the way it should. Other reasons could be because of retained products. Maybe there was some part of the placenta, part of the membrane, something that was left behind did not come out at the time of delivery. Other things that can slow the process, moms who go home and do too much. We don't tend to see this as much with the first-time moms because they're able to kind of go home and take care of themselves a little bit better because they've only got just the baby to worry about. But women especially who have other children at home, and unfortunately the way our culture and society function in America, women tend to have very little help in the immediate postpartum period. And a lot of times women are expected to go right home, jump right back in terms of caring for their families, their other children, their significant others, maybe even going back to work quickly. So being up and being very active can also slow this process down. So we're going to go through the postpartum assessment. We use an acronym called BUBBLE-HE, and you guys actually have those pink laminated assessment cards that break this down for you, but we're going to go through each one of these one by one. So the first B stands for breasts. So lots of things we need to assess with the breasts. It's not just about breastfeeding moms. So we want to know, how is she feeding her baby? Is she breastfeeding or bottle feeding, or maybe she's doing a combination of both? Most women won't get engorgement or their milk won't come in until somewhere between day 2 and 4 postpartum. Certainly it can vary. Some women it may happen a little bit sooner, especially if they've had babies before. Some women, especially if they're a first-time mom or if they've had any complications with their labor and birth, it might take longer than 4 days for their milk to adequately come in. So for the breastfeeding mom, if she starts to suffer from engorgement, we usually say she should do things like frequently feed her baby to keep the breast as empty as she can. She can use Tylenol for the discomfort and ice if needed. If she's a bottle feeding mom, one of the big key things is to avoid stimulation of the breasts. Okay, so we usually say a good snug fitting bra without underwire, so like a tight sports bra is good for her. She can also use ice and Tylenol. Don't stimulate the breasts. So we tell them not to try to hand express any of that milk, because what it does is it tells the brain to keep producing milk, and it's going to make this process last a little bit longer. So if she has no intention of breastfeeding or pumping or any of that, we want to help her avoid stimulating the breast so that she can dry up as quickly as possible. Another thing that works well is cabbage leaves. It sounds kind of ridiculous, but it is actually evidence-based. It does work. Women would take a leaf of cabbage. We tell them to kind of break up the actual veins in the cabbage, so kind of crunch it up a little bit and lay it in their bra. And that will help with some of the swelling and the discomfort associated with engorgement. We want to assess the nipples. Are they inverted? Are they everted? Are they intact? Is there any cracks, bleeding, raw areas, anything that we're concerned about? We also typically are going to do a latch assessment tool, which is on this page here. And we'll talk about this a little bit more in the classroom. But this is where we're essentially assessing the breastfeeding relationship between mom and baby. And we're going to go through and we're going to watch them do a feeding, and we're going to give them a score. And this is going to help us determine how they're doing with breastfeeding and what, if any, assistance do they need. And always remember, even if she's an experienced breastfeeder, she's had many babies before and has breastfed them all, each baby's a little different, and there can be different challenges each time. So then on our bubble HE, the U stands for uterus. We also call it the fundus. So the fundus, that's that top portion of the uterus. It should be nice and what we call firm. When you guys start feeling these in the clinical setting, you'll understand once you feel one that's contracted and firm, you'll know what a normal one should feel like. It should feel almost rock hard under mom's skin. It should also be midline in her abdomen. Shouldn't be deviated to the right or to the left. It should be right in the middle. Usually should be somewhere around the umbilicus. Once again, you got to use your critical thinking. If she had twins or triplets, or if she had a 10-pound baby, her fundus will probably be a little bit above the umbilicus. If she was premature or she had a very small baby, a growth-restricted baby, I would expect her fundus to be a little bit below the umbilicus. It should start to descend each day, usually about 1 centimeter a day. Okay, so each day that you're assessing it, we expect it to be firm, should be midline, shouldn't be deviated to the right or the left, and it should be going down every single day. If you're assessing it and it's not firm, we call it boggy. So that would be a uterus that's not contracted for some reason. So if that happens, we usually tell you to massage the fundus. It's like any other muscle. If you stimulate it, it will hopefully start contracting. Because what we don't want to have happen is heavy bleeding because her uterus is not contracted. And we're going to talk about that here in just a little bit. If her uterus is displaced to the right or to the left, it usually is because the bladder is full. So that's where you'll have to use your critical thinking and determine, is this a patient who is stable enough and it makes sense to have her get up out of bed and ambulate to the restroom and void, or is this someone who either needs to void on a bedpan in the bed, or do we potentially need to either straight cath them or put a Foley in? We want to watch bleeding. If the fundus is not contracted, she usually will be bleeding heavily at the same time. We're going to assess for after pain. So that is, as the uterus contracts and starts doing the work of involution, a woman's going to have cramping. The after pains tend to be worse the more babies you have, or essentially the more work your uterus has to do to contract. So women who have had multiple pregnancies, multiple babies, women who have had big babies, those women, their uterus has to work a little bit harder to contract back down. So their cramping is going to be more intense than a first-time mom who just had a 7-pound baby. Okay. We also want to watch for signs and symptoms of endometritis, which usually what you see is guarding. So when we go to assess a woman's uterus, and we're going to demo this in the orientation day, so you'll get to kind of put it all together and it'll all start to make sense, and we'll have practice time as well. But when we go to assess a woman's fundus, nobody enjoys it. It doesn't feel great. But the patients that are jumping out of the bed almost immediately when you're trying to assess them, those are patients that we worry about in terms of infection. So, if she's not allowing you to assess her, she's writhing in the bed, complaining of pain before you barely even touch her abdomen, that could be a sign of an infection. So then our next B stands for bowel. So obviously we're going to be assessing bowel sounds. We're going to be assessing when they had their last bowel movement. So critical thinking once again. Okay, a lot of women will have loose stools or even some diarrhea in early labor, or with the onset of labor. And then most women during a vaginal birth, if there's any stool in the rectum, it gets pushed out with the delivery. So, and then we're certainly not feeding them a whole lot during their labor. So sometimes it can take women a couple of days before they resume normal bowel function again. So you have to kind of decide, is this just a delay of normal bowel function, or is she suffering from constipation? Okay. That can be because some women may be holding back going because they're worried, because their bottoms are sore. Maybe they have an episiotomy or a laceration, or they have really bad hemorrhoids from the delivery. We also need to think about pain medication that we're giving them that can cause constipation. So a normal vaginal delivery patient that is postpartum day 2 and hasn't had a bowel movement, I'm not overly concerned about that. But if it's a C-section patient and she's postoperative day 3 or 4 and she's not had a bowel movement yet, that's a little bit more worrisome and may require some further evaluation before they go home. So we always want to think about prevention. Make sure these moms are drinking lots of water, they're getting plenty of fiber in their diet, they're up out of